Thank you for coming, and thank you for coming back. I guess you liked yesterday. We'll try to make this fun, and throughout today you'll hear different lectures and cases to really make you all experts by the end of the day in the diet, I think, although many of you are experts already. We'll teach you about some things we've known for maybe about 10 years or 20 years. We'll also tell you some things that are brand new that actually haven't even been published yet, so some exciting new things. What I'm going to start with is I think maybe one of the most important things about the ketogenic diet, which is knowing who to use it for. What are the indications? What are things that I tell my neurology trainees when they're in clinic they should look out for, because those children I know, or I generally know, will do very well with the diet. So 3 things I've always learned when you want to be awake in the morning, because I know it's early. Number 1 is go bicycling. I try to do that. Number 2 is drink coffee. So I did that this morning. Hopefully you all did. And number 3 is start out with some cases, because cases are always a little more interesting than just standard lecture. So we'll start with 3 cases. These are all 3 true cases, children I took care of over the years at Hopkins. The first is a 9-month-old little boy who had refractory infantile spasms. And this is something that I see quite a bit of at Johns Hopkins in my practice. The child had no etiology found, was put on ACTH and had a little bit of a response, but it did not last. Then they tried vigabatrin, and that did not help either. MRI was normal, no structural problem. We heard a lot about structural problems yesterday, but nothing was found on this child. They did a single nucleotide polymorphism genetic array. Nothing genetic was found either. And so the family, and as many of them do, came to me and said, what do you think about the diet? We've tried 2 medicines. The spasms are still continuing. We don't see, at least right now, any obvious surgical choice. What about the diet here? See, no, maybe. Yes. There's a couple nods. Okay. All right. There'll be some tougher cases coming, right, Maria? Yeah. Okay. Second case. Okay. This is an 8-year-old, and this is actually similar to what we talked about yesterday in some of the cases we had in the morning. So this is an 8-year-old who had a right frontal lobe dysplasia, had failed multiple medications, came to us, and actually we did surgery. But as you can see on the MRI, most of it was removed, but not all of it. Our surgeons are good, but sometimes they're not perfect. And so there was a little bit of the dysplasia still left behind. The child had failed 3 medications, and the surgery had been done 3 years before. As a result of the surgery, it was relatively close to the motor cortex, had some weakness. The family was not happy about that, but the child did well for a little while after the surgery, but then the seizures started coming back. And I think the question is, as often is the case, should you do more surgery? So that was proposed to the family. They could go back and sort of clean things up, so to speak. Or, as the family asked, should we try the diet? And so the mother came and saw me, and she says, the child loves to eat butter. I said, okay, that's good, but does it mean anything? Does it mean that this child will do well on the diet? So what about the diet here? Not as simple as maybe the first case. Will it help? Will it not help? Maybe. All right. What about the butter? Good? Should I care? We'll get back to that. There's some interesting new data about parent and patient preferences. Okay. The third case, something we're starting to see more and more now as our adult program is growing, and we'll talk about this. This is a 22-year-old woman who has juvenile myoclonic epilepsy. That is her EEG showing a 4 to 6 per second polyspike wave, usually very responsive to medications. But this girl really had, young woman really just did not respond to medications, as sometimes happens. Didn't respond very well to lamotrigine, topiramate, levetiracetam helped, but was still having some seizures and wanted to drive and was not very happy about that. In the United States, as many of you know, valproate is almost a curse word. You really have a lot of trouble using it in teenage women and certainly women who want to have babies. You're just setting yourself up to go to court. And the family had read on the internet about valproate, refused to try it. I said, if you want to be seizure-free, it may be the best medicine left, but She wanted to have a baby at some point in the near future, so she said no. And so she came to us for our ketogenic diet program. Why? Because she thought that the diet was healthy and alternative, and she didn't like medicines, and she thought this was something totally different, and that she could stop all of her medicines and try the diet instead. The big thing for her, as often is the case in the United States, if you do not have a car, you have no life. And so she wanted to drive. She also potentially wanted to have a baby. Asked about that. Okay. She says the big concern she had was almost every other night she goes with her friends for pizza. And could she do this on the diet? Okay. So what about a case like this? A lot of talking, a lot of counseling, okay, before you just jump into trying diets for someone like this. And a lot of education, really, we'll talk about here for a patient like this. And we'll come back to this. So in today's talk, and it'll be about an hour, and we'll have time for questions, and then I think the cases we're going to do will be a nice sort of transition into some, again, indications. We'll talk about situations when I see these families where I say, yes, okay, absolutely, makes sense, good idea. Make our center look good, you're going to do very well, make my dietitian happy, even more important. But then we'll talk about some cases when maybe we should say, not a good idea, okay? Or you can try it, but the odds are may not be the most helpful for you. And then at the very end, I'll talk about something that's exciting, kind of getting to my thing about butter, that may be the future for how we may think about screening some of these children that is brand new and somewhat exciting, I think. So we talked a little bit about this yesterday. This is what we see in almost all patients 6 months after the diet. Without knowing anything about the child, this is what I can tell them, that there is a little better than a 50% chance of the diet helping, of which about 15%, 10-15% become seizure-free. Very good compared to medicine, probably better than after you failed several medications. This is sort of what we know overall, okay? But if you're like me, and like most centers, you want to look good, you want to maybe have your hospital talked about in the news, you want kids who are going to be here, right? That looks good, that makes you happy, it makes the parents happy, get some presents sometimes, hugs. So when I see 5 children in clinic, okay, and you just sort of look at them, okay, all 5 of these children, people, if you came yesterday, know who this is. This is Charlie, okay. The question is, how are they going to do? And again, I think 20 years ago, the answer was, we don't know. Okay, it's kind of like rolling the dice. You just have to see what happens. But what we would like to know, is there a way that I could tell this, okay, before I start the diet? And that way I can say, this girl who became seizure-free, Charlie, who became seizure-free, I would have known that. Okay, they come to see me in clinic, and I say, you need the diet. Okay, whereas this girl, for sure, and maybe this baby, I would know in advance, not likely to work. Maybe try something else. Maybe try another medicine. Maybe don't try the diet. And I think we've come a long way. If you go back and look, 20 years ago, what was written about this issue? Very little. This is actually, I don't know if people can see it. If not, I'll read it. This is a copy of the very first edition of our ketogenic diet book from 1994. And Dr. Freeman was the first author of this. And he commented on this very briefly. There were actually only 2 paragraphs in the entire book about who should go on the diet. Very, very little, okay? And he said the ketogenic diet is effective in myoclonic, absence, atonic seizures. The diet also helps some children with generalized tonic-clonic and the multifocal seizures of Lennox-Gastaut. So it kind of says lots of different kinds of seizures the diet responds to. Okay, but then he goes on to say, okay, the ketogenic diet may be tried on children with any type of seizure. And then he continues to say, even children with structural brain disorders, prior strokes, hypoxic damage, developmental, pretty much says anything out there can respond to the diet. And so this was, in a way, the height of science in 1994. And we've come a very long way. People knew for a long time that there was really maybe one for sure indication, and that's a condition called GLUT1 deficiency or glucose transporter 1 deficiency. Almost any review, any textbook out there will say this, that this is the indication for the ketogenic diet. It is actually growing in sort of recognition now with the genetic test, the SLC2A1 genetic test. It takes about a month to come back, and we're surprised sometimes by children who have GLUT1 who didn't have what we usually thought was GLUT1. There's a description now of early onset absence epilepsy, such that if you have a child who has what seems to be absence epilepsy and they're 18 months old, 2 years, strong movement from Ingrid Scheffer and the Australian group would say you should look for GLUT1 deficiency. And so some of these children are coming in with this disorder saying, we need the diet. Some of these children don't even have epilepsy. It's pretty amazing. They probably wouldn't see me, and they're sent by another neurologist who says they just have some learning issues. Somebody sent off a big screening bunch of genetic tests and found they have GLUT1 deficiency. So there are foundations out there. The biggest one is from the United States, although there's another big one in Germany too for GLUT1 deficiency, and these families are very interested in the diet, potentially, again, a lifelong therapy. So we knew about GLUT1, but that was it. In 2008, when we put our consensus statement together, we felt that this topic, the question of who should go on the diet, was the most important, because we knew people were going to be reading this who were starting ketogenic diet centers and would want to know who should go on the diet. So table numero uno was the epilepsy syndromes in which we felt the diet was the most helpful. The conditions that we thought were a probable, not definite, but probable benefit, because at least 2 publications were out there suggesting that the diet was even better than that 50% responder rate. GLUT1 deficiency, pyruvate dehydrogenase deficiency, but then also, and we'll go through some of these, DOSA syndrome, tuberous sclerosis, Rett syndrome, Dravet syndrome, infantile spasms, and actually there were several articles about children who were just receiving infant formulas being very obviously compliant and doing very well on the diet, not clear why beyond just compliance. And there was a start that there was some hints for mitochondrial disorders, Landau-Kleffner syndrome, Lafora body, but mostly those were just single case reports where they described a unique benefit. So this is sort of, at least in 2008, what's out. I suspect the next version of this will have some changes. Some of these have had more articles, some of them that were in the suggestion of benefit. Now there have been several articles saying that it can be very helpful for this. And at the end, I'll tell you about some of the new things that are out that are kind of exciting. One of the indications that I'm perhaps most interested in was, like our case number 1, a child with infantile spasms. And this is actually probably even more widely described, believe it or not, than GLUT1 deficiency, is how good the ketogenic diet is for infantile spasms. The very first specific publication on this was 2002 from Doug Nordley in Chicago, and it was a paper about using the ketogenic diet for infants. But if you read the paper carefully, the vast majority of these infants had West syndrome. They had infantile spasms. And he described that of those 23 infants, 72% were responders, so better than the 50% I showed you earlier. 4 years later, a group from Korea had a little bit more patients, similar responder rate, almost identical, that a 70% responder rate, with a third of these children who had, again, failed multiple medications, including vigabatrin and steroids, were spasm-free. We actually had published our papers earlier, but then we updated it in 2010. As our growth of the interest in spasms continued, we actually were now up to about 104. Probably now we're at about 150, I suspect. But when we looked at our numbers, again, maybe not as good as what had been seen, but still better than the average, that about 2/3 of children will respond, with, again, about a third of these children having periods of spasm freedom where they had not had that before. And one thing that we talked about in our paper was how quickly it seemed to work. Generally, within about 2 months, these children, if they were going to respond, had a very good response. And sometimes it was even, you can see here, 0.1 months. Sometimes within a few days, the spasms had stopped. What's nice about it, and this is just to show you all of the formulas out there, it makes a lot of sense. These are infants who are receiving a formula. It's a little bit difficult if they're breastfeeding. You have to kind of talk to the family about that, and obviously very difficult to do. People have tried, but it's very hard. But you can see, besides Ketocal, who was a nice sponsor of this conference, there are other formulas out there, some of which I can't tell you what they say. This one's in Japan, South Korea. This is from a new one from UK called Carb Zero. Lots of these products are on the market, and parents don't always realize this. And so they think that their infant has to be on butter and bacon and eggs. And I say, no, there are baby formulas out there. And so it's relatively simple. Nothing is ever easy, but you still have to calculate it. But it's not too hard to do. I think now it's sort of the state of the world with infantile spasms is I think most of the major academic centers, groups, review articles are now referring to the ketogenic diet as sort of number 3, okay, in terms of steroids and vigabatrin, considering the diet number 3. It has had, if you look, pretty amazing, about 50 papers if you search for ketogenic diet and infantile spasms. So lots of articles being published. In the 5 biggest ones, I showed you some of them earlier. If you add them up, 289 infants, so a large number of infants that have been reported, probably even more that have been tried and just not reported. And this is actually, I think, to show you how interested people are, this is from a United States consensus report on infantile spasms from 2010. And they described, and they tied a whole section on the ketogenic diet, and they said it can be considered as an alternative when first-line therapies, ACTH and vigabatrin, fail or are deemed inappropriate for a patient. There was a consensus in the infantile spasms working group for the use of the ketogenic diet as one of the second-line therapies. So pretty nice endorsement from a group of people who actually, most of this group were not that interested in the ketogenic diet, yet they agree that it is a very good therapy after perhaps these treatments. When we do, as we often do, go back and look at these children in our group and say, who's of these spasm children the more likely to respond? People ask me that. Do people who have idiopathic spasms do better than symptomatic? And it doesn't seem to matter. What did matter when we went and looked was actually the number, it's statistically significant when you accounted for everything, was the number of medications that were tried. So the children who came to see us sooner, who had tried maybe vigabatrin and that was it, or maybe tried 2 drugs, vigabatrin and valproate, did better than those who had tried multiple medications, which sort of raises the question about maybe we should be trying it sooner rather than later. And so this is a girl that I've talked about several times, but I think it's an important case because it's something we're really excited about. This was a girl named Carson. And Carson came to see us through our emergency department. The parents brought her in when she was 5 months old, was previously completely normal, had no prior problems, nothing structural was ever found on imaging or genetic tests, were all normal. And she presented with the abrupt onset of infantile spasms. The family knew right away something was wrong. Her EEG was horrible. After 3 days, they knew something was wrong. They brought her into our emergency room. And again, the usual medications were discussed with them, ACTH, vigabatrin. The family heard about them, talked about side effects, and said, what other choices do we have? And we said, well, there is an option. Okay? We said, you came in so quickly that we might be able to try something a little bit different. And if that doesn't work, then I think you have to try vigabatrin or steroids. And so we offered them the ketogenic diet. The family thought about it for a couple hours. We said, we don't have a lot of time to decide because we need to make a decision. And they said, we want to give it a try. This was her EEG 2 months later. Her spasms actually stopped in about 7 days and never came back. The family has gone on to be extremely important for our center, raising money, and they created a foundation about Carson. This is what she looks like today. And their idea, and what I think is our idea too, is to say to families, look, maybe we should be telling families about the diet, not necessarily at the 10th clinic visit, but maybe at the 2nd clinic visit, just so they're aware of it so that they can at least be part of the decision. The family actually came to the Edinburgh meeting and spoke at the ketogenic conference to all the doctors and dietitians there, and I think did a very nice job of just sort of as parents saying, look, please at least consider it earlier. The other thing that's very important about what they've done and what they're doing is that their daughter is engaged to my son. That's Carson, and that's my son. And anybody know who that is? Anybody been to Baltimore? So that's the mascot for the football team. That's the Baltimore Raven, the bird. Anyway, so, nice outcome. And I think this family obviously was very appreciative that she had a very serious problem, but they did not need to try medications. and they were able to figure out another way, and they've been very helpful in talking to other families too. The other condition that I think people are gradually and quickly realizing is very helpful is DOSA syndrome, or myoclonic astatic epilepsy. This is an epilepsy that people have known for a long time seems to respond to the diet. If you go, and as you know, I love to go on the internet, and you go to the DOSA syndrome's support group, one of the very first things that comes up on their webpage is about ketogenic diets. And this is a girl. I'm going to see if I can get the video to work, because I think it's important to show. A sort of classic DOSA syndrome, normal intelligence, very bright, friendly girl, abrupt onset of these drop seizures. And usually these are the beautiful girls and boys who come into clinic wearing a helmet, and you say, that doesn't make a lot of sense. They're so bright and intelligent to have Lennox-Gastaut. And so these are kids that when we see them, we try to get them on the diet as soon as possible, because we know the diet works very well for it. All right, I'm going to have to go a little, oops. Hold on. Perfect. Okay. Out of the group from Philadelphia, they actually did a very nice review of all of what they had seen in Philadelphia over the years. This was published in 2007, and in their final sentence of the paper, they went on to say that the ketogenic diet was the most effective treatment in this series, and again, it's like we're saying for infantile spasms, perhaps it should be considered earlier in the treatment. What about Lennox-Gastaut syndrome? Lots of people say this is why we should use the diet. It's probably the most common reason we use the diet, okay, if you look at sort of large series out there. But what's very interesting about it was if you actually do a search for ketogenic diet and Lennox-Gastaut, at least if you did a search maybe about 5 years ago, almost nothing came up. And this was interesting. It's, some of the best papers are written when people ask you questions at conferences like this. And one of my colleagues said, hey, Eric, can you send me a paper about the ketogenic diet and Lennox-Gastaut because I'm writing a review article on Lennox-Gastaut? I said, I can't find one. We talk about it, okay, but there really wasn't anything specific to Lennox-Gastaut with the diet except for our crossover study, which we talked about yesterday, where we randomized children to the diet plus sugar or the diet plus saccharin. Those children all had Lennox-Gastaut, but that wasn't in the title. That was the patients, but it wasn't in the title. And those children, as we talked about, did very well. Their seizures got better. So we decided we should change that. So we said, let's first look at what we have at Johns Hopkins in terms of using the diet for Lennox-Gastaut syndrome. And from 1994, if you were very strict about the EEG and clinical criteria, we had 71 children. And then at 6 months, we looked at how they did. And so 51% responder rate, 23% had a greater than 90% reduction. Only one patient became seizure-free. Good, bad? Yeah, it's okay. Okay, I mean, it's not great. Okay, it's about the same as the average. So I think when we looked at this, we said, the diet's okay. I'm not sure it's great for Lennox-Gastaut syndrome, but it's good. Kind of what we think. When we looked at sort of are there predictors of who's likely to respond, we didn't find any. Okay, maybe, as you can see here, a little bit of a trend towards girls doing better on the diet with Lennox-Gastaut, but it wasn't statistically significant. Nothing else seemed to matter. The second part of the study was actually to go look, and I know this is somewhat small, and we looked at all of the papers that were written on the ketogenic diet as much as we could find, and said how many of the children in those large series had Lennox-Gastaut. And you can see here, sometimes it was 10 out of 122. Dr. Caraballo had a study from 1998 with 18 children. 2 of them had Lennox-Gastaut. And so we added up all the patients out there. You can see if you add up everybody, there were about 189 that were part of other papers. And if you look at how they did, 47% responder rate. They had a little bit of a higher seizure-free number, okay, but kind of similar to what we saw at Hopkins they were seeing all around the world, which is about half of children do better. This is well known, and I think people are aware of this, the Lennox-Gastaut community. Again, if you go to the website of the parent support group, they have very high prominence to the ketogenic diet on their website. Unlike bacon, you can see they have eggs but not bad. And so they know a lot of parents are reading about the ketogenic diet because they're interested in it for Lennox-Gastaut. So good information. You can tell a family how likely it is to work. Helpful. Dravet syndrome is also increasing as the genetic test is becoming easier to get. We're finding more of these children. These are children who have an early onset myoclonic epilepsy, often triggered by fever or heat, and then the epilepsy becomes much more clear over time. Lots of interest in that as well. Dr. Caraballo was probably the first to report ketogenic diet use for Dravet syndrome back in 2005. And when you look at these children, there were 20 children with Dravet syndrome published back then. And you can see here, there were certainly some patients, 7 out of 20, who didn't respond or had adverse effects. But a large number of these children had good control, at least to start. Sometimes it wore off. But you can see here, even count up here, 10 out of 20. So half of these children had a greater than 75% reduction in seizures. So pretty encouraging for a very severe form of epilepsy. Does this make sense? Things I've told you so far. Okay? If you read a review article, it says in certain epileptic syndromes, such as epilepsy with myoclonic astatic seizures, Dosa syndrome, putting the fan on, Dravet syndrome, Lennox-Gastaut and West syndrome, the ketogenic diet should be considered early in the course of treatment. Are you convinced? Did I show you enough? So this is actually not my words. This is your friends here. This is actually from their discussion. Maria nods because she wrote this. Back in 2011, when they looked at the series here of 216 children in Argentina, this is the children who seem to do the best. So I think this is good evidence that we're getting better and smarter as we're learning about who does well on the diet and putting these children on the diet. There's some exciting new indications that are starting to come out. We've had some good early work with childhood absence epilepsy, children who still just don't respond to the usual medications. We've often tried the modified Atkins diet and had some good response. The group in Korea is very, very passionate about mitochondrial disorders. We used to think that the diet was not good for those, and now we think it's actually very good for those. It's kind of been a total change in our thought. And then, like my case number 3, we're starting to see some very early interesting results for juvenile myoclonic epilepsy, an epilepsy that previously nobody would think about putting on the diet because it usually responds to medicine, but there are some patients who don't. Just maybe about 6 months ago, we published our results using diet for juvenile myoclonic epilepsy. Most of these patients, 6 out of 8, were adults, like our third case. These were adults who did not want to do valproate, or some of them had failed valproate and therefore wanted to go on dietary therapy. These all were treated with the modified Atkins diet, which I'll talk about in my last lecture. 6 out of 8 had some improvement, including 2 patients who all of their seizures went away, including their early morning myoclonus. But one thing that seems interesting, and I can't explain it yet, is that those 2 patients who became seizure-free and a few others found that they're extremely carbohydrate sensitive, something we don't always see in some of the other epilepsies. A child with Lennox-Gastaut, if they get a cookie by mistake, maybe they'll have some more seizures, maybe not. Patients with JME, it seems like if they get ahead and they get something, and these were some adults who decided they wanted their pancakes or wanted their cookies, had a lot of trouble. Usually very quickly had a lot of their seizures come back. So we're very excited about JME, but we spend a lot of time counseling these patients. And like our third patient who wanted pizza, you would have to tell this patient, absolutely not, okay, unless you want your seizures to start coming back. It's an interesting finding we're seeing with JME. This is one of our teaching sessions. We have patients around a table. What do you see here that's a little bit surprising? These are all adults, okay? So not a single child around this table. This is a photograph from our Adult Epilepsy Diet Center, as we're calling it. We haven't named it yet. Someday we will. This is Dr. Mackenzie Cervenka, who is an adult neurologist, and she sees adults who are interested in the diet. And so we do the teaching kind of like I'm teaching you. We teach these patients around the table with props and information. And this is JME, and then adults with JME and other kinds of epilepsies are coming very quickly to our center. We are almost now at 4 years that the center has been operational. We've seen about 120 patients so far. It's extremely popular. In some ways, maybe more popular than children, believe it or not. About 10% of these patients come to us already on a diet. Either their neurologist started it, but they want some more advice, or sometimes they're children who are on the ketogenic diet, but then, as children do, they turn 18. Then what happens? Right? Somebody needs to take care of them when they turn 18, and usually I have to sort of say goodbye, so they can now come to the adult center. Some of them are second opinions. Some of them have done it on their own and were doing well and just want a little bit of advice. But the vast majority, 90%, are coming because they want to start it because nothing else is helping their seizures. Very exciting center. I won't bore you with all of the details, but lots of things we're interested in for the adults. JME, Dr. Cervenka's very excited about what she's seeing with JME. We have a study to look at the modified Atkins diet alone versus it in combination with Ketocal to see if the Ketocal makes it work a little better. It's a crossover design. What do you do when a 30-year-old starts having high cholesterol? For a 3-year-old, I may not worry so much. We'll talk about cholesterol in my second talk today. But what about for a 30-year-old? So we're very interested in that and what can we do to make their lipid profile better. Some of the new onset epilepsies are coming to her clinic. Adults with brain tumors and seizures. Dr. Cervenka is a woman. She has a lot of interest in women and epilepsy. What effect does the diet have on menstrual patterns? Some interesting things. And then status epilepticus is something as well. She's very interested in using that for adults too. Which brings me to my next point. So these are 3 patients. Okay, one is a baby, one is a teenager, one is a man who's about in his mid-40s. What do all of them have in common? Sad but true. Maria probably knows. So all 3 of these patients were told by their neurologist that they were going to die. These were patients who were in very refractory status epilepticus. This baby was in status epilepticus for about 3 months. They could not stop it. This girl was actually at another hospital, and they recommended withdrawal of life support, and the family refused. And she was transferred to us and said, what else can we do to stop her status epilepticus? She had probably fire syndrome, we think now in retrospect. This man actually had a brain tumor and continued to have status, and they couldn't break it. And so it makes sense. This is a new indication for the diet that I think is really becoming very popular now. It makes sense, right? The ketogenic diet we know works very quick. If you want a therapy for status, you want something that's going to work very quick. We also know that if you have a feeding tube, you don't have to have bacon and eggs and whipping cream and bacon and meats. You can just do a formula. And these patients are usually in an ICU, often intubated with a feeding tube. You can just provide it through the feeding tube. And as well, at least as far as we know, the diet does not have any interactions with lots of other medications. Many of these patients are on antibiotics and steroids and sometimes medications to keep their blood pressure up. And so some nice benefits of the diet. But I am not alone. This is sort of what is out there to date. Lots of articles being published, usually very small case series of a few patients, mostly using ketogenic diet, and at least right now, mostly children. And as you can see in the etiologies, fire syndrome or fever-induced refractory epilepsy syndrome seems to keep coming up as something that responds very well to this. It's a common cause, well, a modestly common cause of status epilepticus. But lots of the other conditions, encephalitis, Rasmussen, seem to be questionably autoimmune, which is exciting potentially to say maybe the diet in this situation has more of an anti-inflammatory benefit. Unknown. Generally, though, when we see it work, it's usually within about 7 to 10 days. So when people call me and they say, I'm at a hospital and I have a patient like this, I give them advice. I say, give it about 7 to 10 days, and then try to see if you can wean them off their pentobarbital or whatever they're on. And if it's successful, great. If it's not, then you can stop. It usually works pretty quickly. The team here has done a great job, and actually this was a series that I mentioned earlier of their 5 patients. I think you're going to talk about one, right, Maria? Maybe? I won't spoil her case coming up. But you can see here, these children all did very well. Where are we here? 3 of them had fire syndrome. Okay, so again, hinting that maybe the diet has some anti-inflammatory benefits. And you can see as well things that we've seen at Hopkins, being seen here in Argentina, that when it works very quickly. Okay, sometimes within hours, sometimes within about 3 days. Very quick response if it's going to work. All right, are there situations, I said all the good things. What about the bad things? Are there situations where I would say to a family, thank you for coming, but I don't think that this is a good idea? So table number dose, okay, was contraindications to the ketogenic diet. We know that most of them are metabolic, which is why we try to screen for these as well as we can. It's not always 100% before the diet starts. Primary carnitine deficiency, fatty acid oxidation defects, porphyria, those are situations the diet would be not a good thing. Okay. The other things that we talked about in our statement was if you can't get nutrition in. This is probably the major reason I say no. The family says, yeah, it takes us about 2 hours to get them to eat a little bit of food. I say, I worry this is not going to go very well. Okay, maybe you should think about a feeding tube before we do the diet. Okay, or there's other issues, maybe that the family is just not comfortable with all the instructions. If they're certainly non-compliant, probably not a good idea. Okay, I sometimes get these calls. A neurologist says, I've got a family, but they're not very good. I'm not sure they're going to understand. I say, oh, this sounds great. That's not a good situation probably to put someone on the diet because it does take a lot of work. But the other thing that I think comes up, and this came up somewhat yesterday and is our case number 2, is if there is a focus that does seem to be amenable to surgery, the diet may not work as well. And so we looked at this back in 2007. We looked at 45 children who came to our center who had something that surgery could have potentially helped. Sometimes as dramatic as this, okay, a hemispheric dysplasia where you would consider a hemispherectomy. Sometimes something's more subtle, maybe again like our case number 2 with a frontal dysplasia. Of these children, about half of them eventually did go on to have surgery, but all 45 of them were tried on the diet. When you look at how they did with surgery, very good response, about 2/3 of them seizure-free and still seizure-free. How many were seizure-free with the diet? 0, okay? Nobody, all right? I'm still waiting for one, okay? Hasn't happened yet to me. A lot of them are better. A lot of them have less seizures, but very, very few of them get to the dramatic benefit that we see. Again, the question comes up, and this is what the consensus statement said about this topic. It said it's not a contraindication, okay, but there's some evidence that children with focal epilepsy may do less well than with surgery. And it said, in this situation, the ketogenic diet may offer a period of both reduced seizures and anticonvulsants, but only rarely a prolonged seizure-free response. And then we actually polled all 26 members of the consensus, and I said, in a case like case number 2, would you offer the diet? And it was actually amazing. You can see it was pretty much 50-50. Half of the experts said, no way would I offer the diet. Half the experts said, yeah, we could offer the diet. So a little bit of mixed opinion. I think the take-home for this is that if you have a case like this, you have to spend a lot of time counseling the family. If the family says, I want my child to be seizure-free, I will not offer them the diet. I say, you need surgery. The family says, we want to be on maybe less medicine, we're not ready yet, we would take a 90% response, then I might say, okay, we can try the diet for a period of time. So, to kind of wrap up some of this and then tell you a little bit about some exciting future things, I think we spend a lot of time even knowing the indications, going through things beforehand. Is the family committed? Does the family understand that this is for 3 months? Okay, not 3 days, not 3 weeks, but really should give it at least 3 months. We ask because if you don't ask, they won't tell you, okay, but can they afford the foods? The foods are more expensive. The ketogenic formulas are a bit more expensive. So we do need to make sure that they can afford those kind of foods. They're certainly more expensive than some of the high carbohydrate foods. Are they willing to come back to clinic? We've been approached. We generally say no, but we've been approached by some international patients. And we say, it's probably just not a good way to do the diet. You should do it in your country because the follow-up is relatively frequent. And so unless they say they can come back from wherever they are every 3 months, we usually don't recommend a diet. Does the whole family agree? Does the grandmother agree? That's probably our worst enemy. Everybody has to know that this is what we need to do, okay? And so sometimes we have unfortunate split families where the mother and father are divorced, and one agrees, the other doesn't agree, and that doesn't usually go very well. Amazing when I lecture internationally and I mention this. There are families in the United States, thankfully not many, who have not cooked. They get ready-made products, microwave products, or fast food. It's kind of sad, but sometimes my dietitian will kind of poke me on the back and say, you know, Eric, this mother's never cooked before. So, sorry. And so she'll actually have to not just teach them the ketogenic diet, but just teach them how to use household measures and how to use some stove. It's amazing. Okay, I talked about butter. Okay, what if you were to ask a child with epilepsy? The average child comes into clinic and you say, okay, here's some choices of food. Okay, you can decide between a little piece of candy, this is called candy corn, and some butter. What would you pick? All right. We would ask parents that, and the parents would always say the candy. The child's going to go for the candy. But what some researchers were telling us, such that we decided to do a study, was they thought that perhaps children with epilepsy actually preferred some of those high-fat foods. And so we went ahead and did a study, and this is actually children who had epilepsy, children who didn't have epilepsy, and here is ketogenic foods, so things like the butter and bacon were given to these children, and we found that children who had epilepsy seemed to prefer to eat the fat, or, depending how you look at it, they tended not to want to eat some of the carbohydrate foods. Very surprising. Whereas children who actually did not have epilepsy, who were a control group, including my daughter, who was actually in the study too, she preferred everything. Okay, most children who don't have epilepsy eat kind of a mix of foods, but they found a very interesting trend towards the high-fat foods. So we were all very surprised. We also found that the parents usually had no idea, and were usually very surprised to see their child eating the high-fat foods. And you say, wow, this is very interesting, but does this matter? Is this just telling us that epilepsy, maybe there's something with fat? So what we decided to do next in the second study, which is actually still in the works of not yet technically published yet, is we looked at 30 children who were about to start either the modified Atkins or ketogenic diet, and we did that forced food preference testing with them, and we said we assume all of them are going to prefer fat, because all of them had epilepsy, but did how much of a preference they have. If they really liked fat, were they likely to do well in the diet versus if they were okay with fat? And so we tested them before the diet, and then we looked to see how well they did. And what we found was sort of mixed results. At 3 months, there did seem to be a trend towards how much fat they liked before the diet correlated with how well they did. But it actually was not significant at 1 month, 6 months, and 12 months. So kind of mixed results. When you look overall, like big picture, how well they did on the diet, there was, again, a trend. So some mixed results, hard to know what to make of it. It maybe suggests that there is something in a fat preference that may be a good way to screen for how well they're going to do on the diet. But it takes time, and it obviously takes a child who can do the testing with you. It takes about 30 minutes. So we're interested in this. We may try to make it shorter, maybe try to do a screening test where they look at pictures and point to the pictures they like. But again, people are very excited about maybe there being other ways to predict who's going to do well on the diet. So stay tuned for more about food preference. So interesting. So getting back to our cases, and then we have time for questions, and then we'll do some other cases. Our 9-month-old, refractory spasms, had failed 2 medications. Diet makes sense? Absolutely. Okay, so this would be a case, absolutely makes sense to try the diet for. We would recommend it to the family. Most of the time they come to us sent in by a neurologist who knows about the studies and says, look, we've tried the top 2. Should we try number 3? Okay, our second case, this is an 8-year-old who had a focal surgery and did well, but then the seizures came back. Could you offer the diet? Yeah, so again, as the consensus, there's a little bit of a mix. You probably could. Again, the family had surgery and was not very happy because the child is weak and still having seizures. I don't think you have to push them for surgery number 2, but I think you have to be very honest with the family and say that the likelihood that the diet will stop the seizures is very, very low, if not zero. Okay, but if the family says, look, we don't want to go back and have more surgery, the child already is weak, could surgery make them weaker? I have to say it's possible. I think you could offer the diet. The mom says the child loves to eat butter. I say, maybe there is something to that. Maybe they are trying to tell you something. Maybe we should give it a try. All right. And then our last case, this is our adult, okay, who has JME. Yes. Yeah, and some new data would say, yeah, actually, that may be a good responder to the diet. The family sees that the diet or thinks that it's a healthy alternative diet. So we'd spend a lot of time telling them, no, that's not true, okay, that this is a medical treatment and that medicines probably would not be stopped. And we're going to, this afternoon, talk about some of the side effects of the diet and what exist. And so I would spend time telling them that, no, there are risks and you have to do this very carefully. Don't just do this on your own. She wants to drive. Could she drive? Maybe. Okay, if we can get her seizure-free, okay, actually our two patients who are seizure-free are driving now. So I'd say you'd have to be very compliant, though, okay, because at least in the United States, it's very state by state. In the state of Maryland, it's 6 months without a seizure before you can drive. So she'd have to be very compliant and not cheat with pizza, okay, if she wanted to be on the diet. So we would spend time telling her all that, and then if she agrees, then we would likely bring her in for our teaching for the modified Atkins diet in our adult center. Muchas gracias.